Hi everyone, I'm super excited. I'm happy to be here with you today. We're here for a treat with Dr. Svetlana Blitshteyn to talk about POTS, postural orthostatic tachycardia syndrome and headache. And why are we doing this? Because POTS is like migraine and headache disorders are comorbidities to POTS, and POTS can be often encountered at headache clinics, can be underdiagnosed, undertreated. Not all of us throughout the world have easy access to a dysautonomia specialist like Dr. Blitshteyn. So I think it's good for all of us to know a little bit more about POTS and headache disorders. So Dr. Svetlana Blitshteyn is a director and the founder of Dysautonomia Clinic and an associate professor of neurology at the University of Buffalo in New York. She completed a neurology training at the Mayo Clinic. She has been appointed as the clinical lead for the Autonomic section writing group for the multidisciplinary PASC, the post-acute sequelae of SARS-CoV-2 infection long COVID collaborative. She has served on the focus group for the National Academies of Science, Engineering, and Medicine Committee on examining the working definition of long COVID. She's on the Medical Advisory Board for Dysautonomia International, Dysautonomia Information Network, Standing Up to POTS, and the Ehlers-Danlos Society. Her research focuses on POTS, autoimmunity, and immunotherapy. I encourage you guys to search her on PubMed to find really good articles. So we're very excited, and thank you so much for you to be here, Dr. Blitshteyn.
Thank you, Dr. Bigassi-Dedem, for inviting me, and thank you to the International Headache Society. I am going to go ahead and share my screen now. All right, and can you see my slides?
Yes.
Okay, very good. All right, so the topic today is headache and postural orthostatic tachycardia syndrome, or POTS. I'm a neurologist specializing in autonomic disorders, and I'm the director and founder of the Autonomic Clinic in Williamsville, New York, which is a suburb of Buffalo. And here I'm also a clinical associate professor of neurology at the medical school, University at Buffalo School of Medicine and Biomedical Sciences. Disclosures, I have only one paid. The rest of my disclosures are all unpaid, but no less important. We'll start with the terminology. And 1 second, let me just get my notes, which I can't see for some reason. There you go. Okay. And so the objectives of this talk is to learn about autonomic nervous system briefly in the time that we have, and to be able to recognize and diagnose POTS just simply in patients, but also in patients with headaches, using the tools that we have, and to also be able to treat them. That's very important. So let's start with the terminology. Dysautonomia is a general term used for any autonomic disorder or impairment. And I use this analogy of headache, which is a descriptive term and doesn't specify the type. Thick textbooks have been written on the topic, but we will concentrate today on POTS. It's important to mention these terms. If you're a neurologist or just a healthcare provider, sometimes it's hard to know what we're talking about. So autonomic dysfunction refers to dysfunction of the peripheral autonomic nerves. And autonomic neuropathy needs to be objectively confirmed on testing. Small fiber neuropathy is not the same as autonomic neuropathy. Small fiber is a type of autonomic neuropathy. Common autonomic disorders are POTS, neurocardiogenic syncope, or NCS, neurogenic orthostatic hypotension, or NOH. Those are the three common disorders. And then we have less common disorders, neurodegenerative or multiple system atrophy, pure autonomic failure, and AAG, or autoimmune autonomic ganglionopathy. We also have rare autonomic disorders such as familial dysautonomia and amyloidosis. What is the autonomic nervous system? Well, I'll be using some of the cartoons from my talented nutritionist, Jill Brooke, who is part of our clinic. And here you see how nicely she summarizes the relationship between the brain and the autonomic nervous system and perfusion. All right, so the autonomic nervous system is an output efferent system that controls visceral function. It consists of sympathetic, parasympathetic, and enteric nervous system. And the autonomic system is triggered by two inputs. One is from the sensory receptors, from the visceral or somatic receptors. And the second one is coming from the brain and all of the areas involved in emotion, homeostasis, or stress response. So information comes in from the periphery, but also it comes in from the central nervous system and the brain. It's very important to remember. All right, so recall from your neuroanatomy and neurophysiology classes what the autonomic nervous system is and what it does. As I mentioned, we have three parts of it: sympathetic, parasympathetic, and then enteric nervous system. And the sympathetic nervous system is, crudely speaking, is your fight or flight response, and the parasympathetic nervous system calms you down. Obviously, the enteric nervous system controls motility and secretion of the gut and defecation. In this little diagram, you see how it basically controls all of the organs: eye, heart, lungs, digestion, colon, pancreas. Everything is controlled by those two or three systems that gotta be in balance. If they're out of balance, then you have symptoms and dysfunction. So just to review briefly, what do we need to maintain perfusion? Well, you need intact sympathetic nervous system that maintains arterial blood pressure, regulates blood flow. What about your temperature control? Also is mediated by the sympathetic nervous system. And of course, your response to stress. But the parasympathetic nervous system is very important for beat-to-beat control of your heart rate, motility of the esophagus and stomach. It also is involved in bladder function and sexual function. And of course, it's the secretory system that controls salivation, lacrimation, as well as pupillary constriction. How do we measure the autonomic nervous system? By performing autonomic function tests. The standard laboratory that you see here in this photo is equipped to evaluate cardiovagal, pseudomotor, and adrenergic functions. So what is cardiovagal function? Well, it tests heart rate response to deep breathing, which is one of the tests we have. And then it also tests heart rate response to Valsalva maneuver. What is the adrenergic function? We evaluate that by blood pressure and heart rate measurements in response to Valsalva maneuver, and also on a tilt table test. And the pseudomotor function is the system that controls sweating, and we measure it by the quantitative pseudomotor action reflex test, or QSART, and thermoregulatory sweat tests. Now, those are beautiful tests. Unfortunately, very few places in the United States and in the world in general have these very nice laboratories. So we have to gather some other data. We have to gather data with tests that are available to most of us, and I'll show you how to do that. So how do we diagnose autonomic disorders? In the same way we diagnose many neurologic conditions. We have to rely on detailed history and exam findings. And I often say that patients don't come to us saying, I have orthostatic intolerance. You have to elicit this history. So you have to ask the right questions. And some of the questions are, do you have any symptoms standing up versus laying down? Do you have any dizziness dizziness on standing? Do you have postural tachycardia? And a lot of people do know what postural tachycardia is. Or you can ask, is your heart racing when you're standing up compared to when you sit down or lie down? Is there evidence of syncope, pre-syncope, temperature dysregulation, and fatigue? All right, that's the history. Then we go on to physical exam. What we look for, where we, of course, we do a full neurologic exam. We look at the pupils. Are they dilated, which they often are, because the sympathetic nervous system, remember, the fight or flight response makes them dilated. Are they poorly reactive to light? Is there evidence of atonic pupils? Are reflexes intact? So we look for that on neurologic exam. And then for neurologists, of course, we have to look for signs of Parkinsonism, cerebellar signs, and gait to make sure there is no evidence of those less common disorders or neurodegenerative disorders that I talked about earlier, such as multiple system atrophy or pure autonomic failure. Okay, so once we do the exam, neurologic exam, we do a general exam, and we look for sign of dryness. Dry lips, dry mouth, dry eyes are common complaints in our patients. Then we look for signs of acrocyanosis. Here's the picture. You see, this is a healthy person standing. This is a patient with spots standing. You see the difference in color, and it's this purple-blue discoloration of the feet. Just, I think last week, there was a case report published in Lancet on a long COVID patient. It was so unique to medical community. I think it made like the national and international news. But it's funny because we have been seeing this in our patients with dysautonomia way before the pandemic, but now everyone is catching up to us. All right. And a very important test we do is after we do the exam, as part of the exam, we do a 10-minute stand test in office by measuring supine and standing blood pressure and heart rate. That's the key. Remember, I said not all of us have autonomic lab. It's very expensive and isn't accessible everywhere. In fact, there are only a few autonomic centers in the country. So how do we, do this kind of work? By doing a 10-minute stand test. Everyone can do them in their clinic, measuring blood pressure and heart rate, and also noticing patients' symptoms, because that's part of the diagnostic criteria for POTS. It's either the 10-minute stand test or a tilt table test. All right, so let's review the diagnostic criteria for POTS, but also NCS and orthostatic hypotension. But before we do, here is I borrowed that from my colleague, Artur Fedorowski from Karolinska. They came up with a new scale called MAMO POTS scale. And here you see very nicely all of the symptoms that can be and that are scored on the scale. Dizziness, palpitations, chest pain, pre-syncope, brain fog, dyspnea, and so forth. But also headache is one of them. So headache is very important in our field. The diagnostic criteria for POTS are three. Number one, an increase in heart rate of at least 30 beats per minute within 10 minutes of a tilt table test or a stand test. So a stand test you can do. Tilt table tests are also widely available. It's the full autonomic labs that are not available as much as we want to. The second criteria is orthostatic blood pressure remains unchanged. So if the blood pressure falls, that's not POTS. If the blood pressure falls, we refer to orthostatic hypotension criteria. Number three, symptoms of presyncope and orthostatic intolerance must be present for at least 3 months. All right, with NCS, or another name for it, vasovagal syncope, you have abrupt loss of consciousness, and it has to be triggered by both fall in blood pressure and heart rate. All right, because if your blood pressure falls, but the heart rate goes up appropriately, perfusion is somehow maintained in the brain, so you don't have loss of consciousness. That's very important. And the orthostatic hypotension criteria is a blood pressure, a fall of greater than 20 millimeters of mercury or diastolic of greater than 10 within 3 minutes of a tilt table test. Now, in the POTS criteria, this is for adults. If you have a teenager, 12 to 19 years of age, the criteria is at least 40 beats per minute. So in teenagers, you need greater heart rate elevation. All right, tilt table test. Tests peripheral vasomotor adrenergic and cardiac sympathetic nerves. Here it is. We check baseline blood pressure and heart rate continuously and beat to beat. And then the patient is tilted to 70 degrees for 10 minutes. And sometimes cardiologists have a different protocol, testing it for 40 minutes to elicit syncope. And then the patient is returned to supine position and blood pressure and heart rate are monitored. And we're also interested in symptoms, not just vital signs, because there is a small subset of healthy people who will display postural tachycardia, but they're not going to be symptomatic. There is going to be a small subset that will increase from supine to standing, maybe from 60 to 90, and they'll be perfectly fine. That's not POTS. And I oftentimes have this argument with my neurology colleagues who tend to question the diagnosis of POTS, but the diagnostic criteria has been set by the Heart Rhythm Society and also by the American Autonomic Society. All right, those are the patterns that we have for tilt table test. The first one is neurogenic orthostatic hypotension. Watch, the blue line is blood pressure, the pink line is heart rate. Look how blood pressure falls when the patient is tilted. And here it is the patient is returned to supine position, blood pressure is restored. But you see how heart rate doesn't go up that much? That's also abnormal. And that's why it's called neurogenic orthostatic hypotension. If you saw blood pressure decline, but heart rate increased like here, it would be an appropriate heart rate elevation and simply called orthostatic hypotension caused by dehydration, perhaps, or anemia or so forth. So neurogenic, the word neurogenic refers to the fact that heart rate doesn't pick up continuously. And this implies a barrier reflex problem. All right, that's the first pattern. This is the second pattern for POTS. So you can have a blood pressure that's fairly holding, but look how the pink line goes up, heart rate increases until the patient is returned back to supine position, then it normalizes. Well, that's abnormal too. Why would heart rate increase inappropriately? Well, during this time, the patient is going to be very symptomatic. They're going to feel sick. They're going to feel like they're going to pass out. They're going to feel palpitations, or they may feel nausea, or they may feel headache, or they may have leg weakness and say, my legs feel like cement. So those two important patterns. There are others. There is a pattern for vasovagal syncope. There is a pattern for, severe orthostatic hypotension of AAG or pure autonomic failure where just blood pressure declines continuously. But those are the two common ones. All right, what are the symptoms of POTS? Many. If you have POTS, you know it, but if you also see patients with POTS, they're very symptomatic. The symptom burden is very high. We arbitrarily divide these symptoms into those of cerebral hypoperfusion, those of sympathetic activation, and then associated manifestations. That's one criteria that my Mayo Clinic colleagues use. But there are other ways to classify. The cardiologists use, cardiovascular symptoms and non-cardiovascular, and then other people use orthostatic and non-orthostatic. But that is to say that we have central nervous system symptoms, lightheadedness, dizziness, weakness of the legs, generalized weakness, brain fog. We have symptoms of sympathetic overactivity, which is one of the major pathophysiology of POTS, which is going to be the tachycardia, the tremulousness, feeling physically anxious, as they call it, chest pain. Autonomic storms, what are those? Well, those are episodes of sympathetic overactivity, which involve high blood pressure, high heart rate, but could also be actually low blood pressure and high heart rate. The patient may feel flushed, shaking, and they feel anxious. So they can be confusing with panic attacks. But I think they are very much different because a lot of panic attacks can be associated with certain psychological trigger or thought patterns. In the case of our patients, they're often triggered by dehydration. They triggered by exertion, by illness like COVID, and they can also be triggered by hypovolemia, anemia, but also a mast cell kind of trigger where they eat something and they don't feel well after dinner or something like that. So interesting phenomena, not to be confused, can be hard to differentiate from panic attacks. All right, associated manifestations are migraine, which is the most common comorbidity of POTS, and various GI disorders, including gastroparesis and IBS. The demographics for POTS is actually quite unknown right now. But before the pandemic, we estimated 1 to 3 million of Americans had POTS, and now with COVID, the estimations are that it's possibly twice as much, because about 70% of patients with long COVID have autonomic dysfunction. Not all of them POTS, but many are would satisfy the criteria. So we just don't know right now, but the numbers are in millions. Most of them are women of childbearing age. Most of them are Caucasians, but there are also, Asians and Blacks seen in clinics. We don't know why there is racial disparity. Certainly, there are genetic predispositions for this type of autoimmunity from the Europeans, but also there may be a variable absorption in sodium in renin-angiotensin aldosterone system, and we talk about that in our case report on an African-American patient who had POTS and had difficulty getting diagnosed because presumably doctors are thinking that this is a disorder of white women. So he had difficulty getting diagnosed, and we had a discussion on that here. All right. POTS comorbidities are many, actually. It rarely exists alone. At least 80% of patients have some kind of comorbidity, and the most common one is migraine headache, affecting at least 40% of patients. Then we have joint hypermobility syndrome or hypermobility spectrum disorders, including EDS, Ehlers-Danlos, at least a third. We also have small fiber neuropathy, which is a different topic. At least 50% of patients with POTS have evidence of small fiber neuropathy, if not more, given the limited testing that we have. Autoimmunity is common. At least 20% of patients have some kind of comorbid autoimmune disorder. Most common is Hashimoto's thyroiditis, but there are also others: rheumatoid arthritis, lupus, Sjogren's, antiphospholipid syndrome. Mast cell activation syndrome is another entity that we need to talk about. And certainly there is disagreements on diagnostic criteria and what should be used. Should it be strict? Should it be broad? But if you do this kind of work, you know that many patients have sensitivities and reactivities and all kinds of allergies, as well as a history of allergy. And oftentimes antihistamines are very helpful. We also don't know how many have immunologic dysfunction, especially with now post-COVID POTS. Many people display some kind of immune system aberrations. Impaired metabolism, mitochondrial dysfunction, those are new topics. I think at the end of the day, a lot of patients are going to be having autonomic dysfunction from mitochondrial dysfunction because it affects the energy. A lot of our patients have comorbid chronic fatigue, and at least 20% actually satisfy the criteria for ME/CSF. All right, so we'll talk about autoimmunity next. And years ago, as I said, I noticed in my clinic a significant number of my POTS patients having positive markers of autoimmunity and comorbid autoimmune disorders. So when we applied statistical analysis, we found that POTS patients had a higher prevalence of ANA, antiphospholipid antibodies. Here you can see it in the table, than the general population. And also, as you see from this figure, the prevalence of most defined autoimmune conditions was higher in my patients. There was a 100-patient cohort than in general population, with any autoimmune disorder affecting 1 in 5 patients. With POTS, Hashimoto's thyroiditis, 11%. 25% of our patients had positive ANA, and that was higher than in general population. So there is autoimmune basis, no doubt, in our patients. All right, so what antibodies have been discovered in patients with POTS? there has been significant research interest in POTS as an autoimmune disorder. And while we haven't conclusively answered this question, it appears that POTS may have a strong autoimmune basis. As you can see from the slide, various antibodies have been identified in patients with POTS. These antibodies are critical to the structure and function of the sympathetic and parasympathetic nervous system. So it makes sense that these antibodies could be potential biomarkers in this disorder. So in 2020, we've made significant progress. We actually had an animal model of a rabbit with adrenergic receptor peptide that was created by immunizing the rabbit, and the rabbit having signs of actually POTS. So therapeutic implications are many. Should we be using immunotherapy such as IVIG, subcutaneous immunoglobulin plasmapheresis? Should we be using medications with B-cell depletion action? Should we be moving towards immunoabsorption? This is very important. And you see this cartoonist actually outlined that very nicely in the cartoon on the topic here. All right, so what is the pathophysiology of POTS? We often say that POTS is multifactorial, that it's multisystemic, and that it is complex. And this diagram from my recent paper called Is POTS a CNS Disorder shows all of the known major mechanisms of POTS. And that includes the G-coupled receptor antibodies. It includes hypovolemia, cerebral hypoperfusion, abnormalities in the renin-angiotensin-aldosterone pathways with salt absorption. And this is a proposed model that makes sense to me. And hopefully, as we go further, we can add the missing pieces. This was a paper actually pre-pandemic, and now we're learning more about neuroinflammation at the brainstem level. We're learning more about autoimmunity and the cytokine changes in post-COVID patients. So I think at the end of the day, we'll probably see some type of neuroinflammatory changes at the level of medulla, which is where the vagus nerve comes from, and a very important area for autonomic control and central autonomic networks. But autoimmunity and various genetic phenotypes will certainly be playing a role. I do want to mention this concept that in the process of research came to me, is that hypovolemia may lead to reduced CSF volume, which may lead to cerebral hypoperfusion, or there is some kind of interplay. And it may be that's what driving this orthostatic headache. When our patients stand up, they have orthostatic headache. There are no evidence of CSF leaks when you evaluate them, and yet there is a coat hanger headache. So interesting phenomenon. Obviously, we don't tap patients when they stand up. We can't measure their CSF pressure, but I think this might be one of those things that could potentially explain this orthostatic headache. All right, treatment of POTS includes non-pharmacologic measures and pharmacotherapy. I won't go into details, but let's briefly summarize that it's important to implement non-pharmacologic therapy. The staples are increased fluids and salt intake, high salt intake of 7 to 10 grams per day. We often recommend waist-high compression stockings or abdominal binders. We recommend recumbent or sitting exercise, mild. It's not going to be anything big, but certainly movement is important. Lifestyle changes, coping, biofeedback, gluten-free diet. We had a study out last year, a small study that showed the benefits of gluten-free diet in patients with POTS, especially those with the triad of POTS, EDS, and MCAS. Pharmacotherapy is very important. The staples are beta blocker, fludrocortisone, midodrine, pyridostigmine, or mestinon, the old myasthenia drug that improves parasympathetic outflow. We also have ivabradine or Corlinor, which is an ion channel blocker for heart rate. Clonidine, the sympatholytic, but we also use stimulants, modafinil, methylphenidate, because of fatigue and brain fog, and the histamines. are also, and they're over the counter, so they can be very helpful. You don't need a prescription, but a lot of patients feel that over the counter Zyrtec, Allegra, or Claritin, in addition with Pepcid, can be beneficial towards many of their neurologic symptoms, including headache. So, of course, we use headache medications. SSRIs are not my first line treatment options, but certainly if there is anxiety, depression, or significant orthostatic hypotension, certain SSRIs can be very beneficial. Benzodiazepines we try not to use as a routine, but sometimes there is severe insomnia or there is severe panic or anxiety disorder, and we would use that temporarily. Droxidopa is FDA approved for neurogenic orthostatic hypotension. Low-dose naltrexone can be good. We need more studies, but I certainly use it in my patients. And then other therapies, the immunotherapy, steroids that I mentioned in severe cases. This IV fluids as needed is very important because hypovolemia is one of the major mechanisms of many autonomic disorders. And when you replace these fluids, patients feel a lot better. Non-invasive vagus nerve stimulator comes to mind, and we know it's FDA approved for treatment of migraine and cluster headache, and now it's in clinical trials for POTS, for gastroparesis, for neuropathic pain. All right, this is the table outlining exactly what I just talked about, and you can find it from my paper on headache and dysautonomia and long COVID that was published last year in Practical Neurology. When it comes to patients with migraine and POTS, what should you be using? That's always a good question. So, of course, beta blockers. We love them. They're good for tachycardia, they're good for sympathetic overactivity, and they're great for the headache and migraine prevention. The problem is that many of our patients cannot tolerate high enough doses for migraine prophylaxis. So we have to find low doses. And usually I use propranolol. I start very low, 5 to 10 milligrams twice a day. If patients cannot tolerate non-selective beta blockers, then I go with cardioselective. In fact, I prefer them because they're much better tolerated because they don't go to the brain. And our patients are very sensitive. Sometimes you see paradoxical increase in anxiety, increase in headache, where we know it's supposed to help. Why are the patients reporting these kind of, exactly unexpected things? Because our patient is somewhat of a different population than general population. It's important to note. They are sensitive, whether genetically or through mast cell hyperactivity. So we have to be mindful of that. Ciprofloxacin, Periactin, is FDA-approved pediatric migraine medication that works very well in many of our patients. It has the antihistamine properties, so it's good for mast cell hyperactivity. Patients tolerate that well. The side effects, of course, are somnolence and also weight gain, so got to be careful to titrate up and use it at bedtime. Amitriptyline low doses can be used, but at high doses, it can give you worsening of orthostatic intolerance because of its anticholinergic effects. Gabapentin can be well tolerated, again, low doses. IV saline is needed. I use it when patients deteriorate. And incidentally, not uncommonly, they also told me that their headaches are better after a bolus of saline, like 1 to 2 liters. For migraine prevention, certainly Botox, CGRP inhibitors, and non-invasive vagus nerve stimulator can be used. All right, so prognosis in POTS is very much variable. You have to look at it as a chronic illness. In studies, we know that only 19% of pediatric patients recover or identify themselves as recovered. Remember that it's not uncommon when these recovered patients then have COVID or flu and they come back to see me because they were doing so well and now they have significant symptoms. At least 25% of patients are very disabled and cannot work or attend school. Actually, more in my clinic. In clinics, usually the number is like 40 to 50%. Disability is comparable to COPD and CHF from a Mayo Clinic study. It's best to view POTS as a chronic disorder that fluctuates in severity. Of course, there is a small percentage that will almost recover or that will go on with very minimal symptoms. They tend to be men, and they tend to have very low comorbid conditions. All right, so types of headaches in POTS. Most common one is migraine with and without aura. Chronic migraine is very common. Tension headaches. Vestibular migraine is not uncommon. A lot of our patients have vestibular complaints. Chronic daily headache, new daily persistent headache, especially in patients with post-COVID POTS or long COVID. And then there are these coat hanger headache, orthostatic headache, cervicogenic headache, which I think, all are rooted in orthostatic changes in perfusion. Medication overuse headache syndrome is also uncommon. This is a box of clinical scenarios that is taken directly from my paper in Practical Neurology. And it gives you guys in headache medicine scenarios, common scenarios that you see, that I see, that would prompt you to think about an autonomic disorder, well, whether it's POTS or syncope or orthostatic hypotension. Usually those are very sick people with intractable migraine, like you treat them with everything you have and they're still very sick. Or it's usually people whose migraine is now under better control, yet they're still dizzy and fatigued and complain of brain fog and difficulty functioning. Or these are people with predominantly orthostatic headache that is much worse when they sit or stand, but when they lie down, they feel much better with their headache or neck pain, and that's this entity. You certainly need to rule out a CSF leak because there is a subset that, especially the EDSers, with abnormal collagen and abnormal dura that may have spontaneous CSF leaks and may have secondary headaches, not primary. There are also intractable headaches or lingering headaches after concussion. People with EDS and a lot of systemic comorbidities, joint pain, hypermobile joint or joint disease or GI problems, think about a wider spectrum. And of course, we want to concentrate on our field, but the problem is if you miss comorbidity or underlying systemic issues, a lot of people are not going to improve. It's only when you address the comorbidity that they generally may improve and may function better. So it's not very simple. It's actually quite complex. All right, so the clinical pearls to finish with is always do orthostatic blood pressure and heart rate. Get a tilt table test if there are spells that you can understand. Don't diagnose functional neurologic disorder without going through proper workup and ruling out autonomic dysfunction. POTS is not just about the vital signs. As I said, symptoms are very important. The most disabling treatment-resistant symptoms are actually not headache or tachycardia. It's actually fatigue, dizziness, and brain fog. We don't have good treatment options for these symptoms. Of course, you've got to treat comorbidities, migraine, neuropathic pain, joint pain, insomnia. And some of the MythBusters, again, my nutritionist Jill Brook, the cartoonist, hopefully she's on this webinar, but maybe not. And so she nicely represented what is POTS and the interplay between the brain and the heart. And when the person stands up and there is hypoperfusion, brain doesn't have enough oxygen or starving, the heart starts freaking out. Essentially, that's what happens. Important to mention that certain MythBusters that I end my lectures with to clinicians is that POTS is not caused by anxiety. Certainly you can have anxiety as a symptom, the physical anxiety, but also you can develop psychological anxiety from chronic illness. POTS is not caused by deconditioning, but deconditioning secondary to exercise intolerance is common. POTS is not functional neurologic disorder. Go through proper workup to rule out autonomic dysfunction. SSRIs are not the first choice of treatment. Maybe a third choice, but not the first choice. Beta blockers, fludrocortisone, midodrine, prostaglandin can be used. Always use low doses. Slowly increase to maximum therapeutic effect. Our patients are sensitive people. And then don't forget about oral fluids, but also when the patient is very sick, when they have COVID, pneumonia, flu, or maybe they overexerted themselves on a recent trip or something like that, then you can use IV saline during flare-ups and not daily. And so this is it. Thank you for inviting me. These are some of my research assistants. They are medical students from Jacobs School of Medicine, hopefully future neurologists. On top, you see me teaching a course in Baltimore for the American Academy of Physical and Rehabilitation Medicine on long COVID dysautonomia. And then here is our women neurologist group in Boston this year at the American Academy of Neurology. And we can do our questions now. So thank you for having me over. Hopefully this lecture is going to be useful in your clinical practice.
Thank you so much. We really appreciate it. And yeah, a lot of questions came up, including questions about the 10-minute standing test. Like if people cannot tolerate standing for 10 minutes, can you say as a POTS or as a other diagnostic criteria? Some people are afraid of patients having some orthostatic intolerance, but no formal diagnosis.
Right. So got to make sure they are safe. Usually I put them facing me and with their back towards like a chair or something, because in case they're dizzy, I don't want them to fall in my clinic, And of course, you have to abort the test. If they feel like they're going to go down, then you do it for 5 minutes or whatever it takes. And that's why this is a crude way of us assessing a patient. It's best to do it on a tilt table test that is equipped to dealing with these issues and can actually measure the heart rate and blood pressure immediately before the patient passes out. That's very important. To add a little layer is that hopefully soon we will have a test for cerebral perfusion where on an app we'll be able to see cerebral perfusion going straight down right before the patient says, I'm going to pass out. And I know that some people are developing this technology, so it will be very exciting to see.
Wow, that's really cool. We have to be on the lookout for this app.
Yes, and I'd also like to thank Svetlana Blitshteyn very much for this excellent lecture. And I'm chair of the education committee, and I would like to also be asking some of the questions from the Q&A. And there's one from Ryan Parsons, where he's asking, as a clinician, have you encountered symptoms of dysautonomia and cervicogenic type headache as a direct result of neuromuscular dysfunction in the neck, like in the sternocleidomastoid muscle and trapezius muscle?
So usually not from the muscle weakness, but there is an entity that's out there called CCI, craniocervical instability, where internally the ligaments are loose, and that's especially a problem in patients with Ehlers-Danlos syndrome. Then we have, what do we do? How do we assess? That's an entity that's not taught to us or even a lot of neurosurgeons. And a lot of the times it would require an upright MRI, because on supine MRI, everything looks good. But on upright MRI, you see the sagging cerebellum and you see this kind of abnormality. Then the radiologists who know these syndromes can measure the proper angles to see if there is a compression, the medullary compression. So very important area, which I absolutely have to follow up with. What do you do for it? Because that's what patients ask me. Well, what do you do? Do I need surgery? And of course, only very few people will require surgery to correct that. Majority of EDSers are not going to be candidates for surgery, nor do you want a surgery, because there are surgical complications with hypermobility spectrum disorders. So you try to address it conservatively with conservative management, physical therapy, soft neck brace, other modalities. It's a very big topic.
As you mentioned, unfortunately, POTS can come with severe disability, and then the fatigue, dizziness, brain fog, not much good treatment for that. Do you find in your patient population the symptoms are worse standing up? Like, is trying to work from home, lying down, a reasonable accommodation that work, or other accommodations that can help?
Well, now with long COVID, a lot of people find themselves unable to return to work. And many people do need to work, do want to work. So reasonable accommodations can certainly include reclining workstations. Our patients are able to work, people able to study and contribute, to society and obviously to their own income, but they need to be accommodated for, because prolonged sitting, just like standing, is going to be very difficult. Remember, the concentration, perfusion can all go down. So, of course, employers want to improve the performance, and so working from home is a good option for our patients. In fact, we have patients with POTS who couldn't work, who couldn't attend school, and now with the pandemic, now finally have access to employment and learning opportunities. This is all very important in terms of, society and ableism and all that.
Thank you. So we have an interesting question from Debbie Buckley, who's asking about a possible link between estrogen hormone fluctuation and occurrence of POTS, maybe also in relation to headache. Is that something
home oxygen saturation?
Estrogen hormone fluctuation.
Oh, estrogen. So,
yeah.
I see. Yeah,
so
I mean,
cycle.
Yeah, there is certainly a hormonal fluctuation, just like there can be hormonal fluctuation with migraine headaches. The same and worse are in patients with POTS. Oftentimes, people feel very sick with PMS or at the start of the period. And it's not only the hypovolemia, it must be the fluctuating estrogen progesterone. Sometimes our patients do well with continuous oral contraception, if they can tolerate, if they're young, if there are no comorbid hypercoagulable disorders, then that can be tried. But this area is also not heavily researched, the sex hormones and what to do about them.
You mentioned treatment of POTS and then what we use in migraine too. Are there some of the migraine treatment that we should avoid in POTS? Like some people with triptans have dizziness or lisinopril or candesartan as migraine preventive or SNRIs.
Yeah, that's a great question. What to avoid? I don't believe there is anything specific to avoid with POTS, except for, of course, medications that can lower your blood pressure. And so the anticholinergics in high doses, we are taught in headache medicine, where you can go up to 75 milligrams of amitriptyline or higher, or nortriptyline. And that's and some people will tolerate that, but oftentimes that may result in worse dizziness or anticholinergic side effects. So I try not to go that high. I try to leave it only like at 10 milligrams or 25 or something like that, low doses.
Right. If we stay on the track regarding treatment, there's a question from Professor Manjit Mathur about a common scenario in patients with POTS and orthostatic headaches, where they have been treated, for example, with midodrine, ivabradine, pyridostigmine, and it leads to improvement of cardiovascular component, but the orthostatic headache persists. So how do you account for the ongoing orthostatic headache in this scenario when the parameters have improved? So interesting question.
Yeah, because it's so complex and none of them are major cures. Like in migraine, you can put the patient on Topamax and they're doing so well. In our patient population, things are much harder and more complex. And certainly there is partial response to treatment. So I take everything as like a good thing. If the patient tells me, well, I'm 20 to 30% better, it's good. In my field, that's a good thing. You need to also look at the mast cell component. And sometimes when you add, like famotidine and Claritin, that can also improve. Sometimes when they go on a diet, and that could be gluten-free or anti-inflammatory diet, that can further cause the improvement. But sadly, there is no magic bullet, and you tweak a little bit here, you address hypovolemia, you address headaches, you address low blood pressure or high heart rate, and then globally people feel better. But are they cured? And in many cases, they are not cured. We have to make them well enough to function better.
Because there's a question that was asked and other people liked it, so I feel like now is the time to ask it. Do you find muffled hearing to be a common symptom of POTS?
Muffled hearing?
Mm-hmm.
So various ENC symptoms are there in our patients. That's another minefield. And if you add that a significant proportion of our patients have hypermobility spectrum disorders and mast cell hyperactivity, suddenly it makes sense, connective tissue, mast cells releasing various mediators. So muffled hearing, as you know, can be also part of the migraine complex. I think I heard the lectures on or something like that, like a migraine in the ear, where this can be like an aura or the actual episode. So these are very much connected. There are also inner ear probably changes. There is a lot we don't know, how brainstem controls the vestibular function. So I think the muffled hear, tinnitus, hyperacusis, or decreased hearing, we just don't know. I mean, my question always is, are these all symptoms of cerebral hypoperfusion? Are these symptoms of altered CSF flow? So lots of areas for research. And, I always, my headache colleagues and I are always talking, exchanging ideas. I always read your literature because it's so important to our field as well.
Great. I hope it's okay if we go a little back and forth. There's also a few questions regarding treatment, something that has not been mentioned, the use of nicotine, and there's a question regarding that. Is that something like nicotine patches? And there's also a question regarding the use of oxygen inhalation. So are those two approaches something that could be useful?
There is nothing in our literature on oxygen or nicotine patch. Certainly, some people will use, oxygen is one of the therapies for cluster headaches. And sometimes patients will come upon something that works for them. We just don't know why. And I am of the mentality, if it's safe, if there are no adverse events and you can afford it and it helps, I am fine with letting you do whatever you need to do. Now, nicotine patch, again, there are some mentions of that in long COVID literature, but there is nothing formal with POTS.
And then you mentioned temperature dysregulation. As a certain temperature changes that make POTS worse, or things to look for from a temperature standpoint?
Yeah, usually people will notice that they became heat intolerant. And especially with long COVID, it's very interesting. A lot of people were, young and healthy, were at the beach, and now they say, when it's hot out, I feel much sicker. A lot of the times it's heat intolerance. Sometimes it's cold intolerance, or both.
There's also a question on this mast cell activation syndrome. How comfortable are you to diagnose and treat coexisting MCAS? Do you have any support from immunology? This can be hard to access in the UK. That's a question from Jim Benham.
Yeah, I mean, it's hard to, get a diagnosis here in the United States too. So I have a bunch of tests I learned from my colleagues who do this work. There are a number of serum and urine mediators that we can measure. Labs are equipped to do that. The key is they are highly sensitive to temperature. So if they are not chilled, they're going to biodegrade and result is going to come back normal. All right, what are the better way to diagnose it? Well, if the patient has colonoscopy or endoscopy, the tissue can be stained with CD117 stain, and the mast cells can be counted under microscope. And in many of those cases, there is a higher number of mast cells under microscope than in healthy people. That's how you know. Most of these patients do not have mastocytosis, which is a rare form of blood cancer, but sometimes, a hematologist or an immunologist will order a bone marrow biopsy just to make sure, and most of the cases it's negative. So is tryptase. Serum tryptase is widely used as one of the diagnostic criteria for mast cell or anaphylaxis by the Allergy Society, but 95% of our patients have normal tryptase levels. So it's also on clinical basis. You'll know when you see them, they're going to be highly reactive, and they might not be reactive to the actual active ingredient. They might be reactive to excipients and dyes of the medication. So with my highly sensitive patients, we go through compounding pharmacy, where the medications can be compounded in safe or well-tolerated ingredient form. Very hard, because we use medication to treat patients. But what if they react adversely to all of the stuff that's in the actual medication? I do that on clinical basis. I say, let's try over-the-counter Zyrtec and Pepcid. And sometimes they feel better. Occasionally it will be like, oh my God, I feel so much better. It almost like a kind of a miraculous improvement. And if it doesn't help, we get rid of it. We give it a try of maybe a month or two. And then if it doesn't work, I never keep medications that are useless for patients, because obviously we don't want polypharmacy for our patients.
Wow, I love everything about this talk. I'm learning so much. Even I didn't know about the stain from endoscopy. We need more people like you. That's one of my conclusions. Do you have any recommendations about exercise and POTS?
Right. So, exercise is one of the recommendations for non-pharmacologic treatment option. And when we say exercise, we have to understand it's not going to be the regular exercise that physical therapists are knowledgeable about, in patients with migraine or back pain or even multiple sclerosis. It has to be a very slow program that usually involves supine and recumbent exercise. And sometimes people are so sick, they're in bed, and it will be exercise from bed. The Autonomic International has a list of these exercises you can do supine. We have a physical therapist that works with our patients virtually. She meets them at their level and then slowly progresses them to, maybe sitting exercise. Swimming is very good because, gravity impact is much less in water. So it is important, but it has to be done right. The patients cannot be rushed, cannot be expected to do too much. As well. And then, ME/CSF patients, that's really, really tough. And we need to have more studies on what they can safely do with spacing. What does it look like? What does it look like in real life to advance them, but yet not cause them, setbacks and post-exertional malaise?
Good. Thank you so much. I think we'll just have maybe a couple of more questions, and then we'll thank you so much for answering all these questions so well. I think that there's one interesting. It's about if you're a POTS patient whose blood pressure is increasing in upright position. I don't know if that's a common phenomenon. Are there any specific therapeutic options when fatigue is also a problem which gets worse with antihypertensive medications?
Right. Orthostatic hypertension, HYPER, can be a problem and can be a feature of patients with POTS. Why that happens? Well, because it might be when there is a hypovolemia, your blood vessels now constrict too much on stanzing in order to keep you upright. Sometimes there is hyperadrenergic state with stanzing epinephrine and norepinephrine. The criteria is greater than 600. Sometimes people meet the criteria for hyperadrenergic POTS. We approach it actually not dissimilar to the regular POTS, except I may use more beta blockers, higher dose, and I may use clonidine patch for superimposed hypertension, but also address the blood volume. And in hypertensive POTS patients in general, you want to be very careful with medications that are designed to increase blood pressure. So my go-to would be Mestinon. Mestinon doesn't raise blood pressure. My go-to would be beta blockers, clonidine, volume replacement with, believe it or not, fluids and salt. Interestingly, paradoxically, if you take a patient with hyperadrenergic state and orthostatic hypertension, or sometimes supine, they come with spots, they feel very sick, you give them a bolus of saline and you see their blood pressure come down, actually. You know, like it's counterintuitive because hypertension, how can you give them salt and fluids? But because it corrects the hypovolemia and reactivates the constriction, you see their blood pressure and heart rate coming down, and they're actually feeling better.
This is very interesting. Someone was asking, when do you keep looking for secondary etiologies for POTS? Like at what point do you say, oh, it's idiopathic POTS, or look for comorbidities and then also treat the comorbidities?
So I always, from the first visit, I'm going to look for all of the potential comorbid conditions and underlying causes, because by the time they see me, they've seen, 15, 20 doctors, a lot of whom unfortunately were not helpful. So I'm going to look for autoimmune markers. I'm going to look for inflammatory markers. I'm going to look for vitamin deficiency, because a lot of our patients have low iron, and that can drive, low volume and dysautonomia. A lot of our patients also have vitamin D deficiency, maybe more than the general population. I also usually check, thyroid. That's important because you may have normal TSH, normal thyroid hormones, but you may have elevated thyroid antibodies. And sometimes the subclinical thyroid disease can result in tachycardia or this hyperadrenergic state. So I always run, a big workup. I'm not good for insurance companies because I don't save them money, but that's okay, because I think it's important to make sure we're not missing anything. There are guidelines out there from cardiologists who do minimalistic stuff like an EKG, blood pressure, heart rate, and maybe a couple of blood tests, but I tend to be quite thorough. So I always look for underlying causes.
All right. I think we should wrap up this webinar. I'd like to thank so much to Svetlana Blitshteyn for doing an excellent lecture and for answering all these excellent questions. So I'd also like to thank all the participants for being active and asking questions. And I'd like to thank my co-host Olivia Begasta-Daim for actually setting up this webinar and for getting the idea to do this webinar. And this webinar is being recorded and it will be released soon on the International Headache Society webpage, where it will be available. So I urge you to go into the IHS webpage and also to become an IHS member if you'd like. There are many benefits from this. That is it for now. We'll plan future webinars also, and if you have any suggestions, you can write to the IHS Learning Center to make up suggestions for future webinars. But thank you so much for listening. Thank you so much for participating in this, and have a great evening, afternoon, wherever you are. Goodbye.